All right, welcome to another deep dive with us. We're Harvey and Donna.
And we've both spent years, reviewing those MCCQE exams.
If you're a Canadian medical student getting ready for this thing, let's face it, it can feel pretty overwhelming.
Yeah, it can be a lot.
That's why we're here. We want to make you feel more at ease, with all those major concepts the exam throws at you.
Think of us like your study buddies,
Yeah, like your guides.
highlighting the need to knows, especially from solid sources like stat pearls.
Right, we'll break it all down.
Make it clear, make it digestible.
Before we jump in, though, quick reminder, this
Mm-hmm.
is a medical advice, okay? Just for education.
Exactly. For learning, always consult a qualified healthcare provider for any health concerns.
All right, now let's dive into something you'll definitely see on the MCCQE.
CPR.
Oh, yes, CPR. This is essential stuff.
It's a literal lifesaver, and you got to know it backwards and forwards.
Inside and out, yep.
Stat Pearls actually gives this pretty startling statistic. Almost 350,000 Americans die every year from heart disease. Heart disease, it's a big one.
And get this, half of those deaths happen suddenly, outside of a hospital.
That's where things get really interesting, right?
Exactly. Think about it. You're a future physician. Are you ready to react in those critical moments?
This is the real deal. It's not just about acing an exam.
So let's get to the heart of it. What is CPR?
Well, you can think of CPR as a series of interventions, things you do to keep the oxygen and blood flowing during a cardiac arrest.
It's like manually stepping in when the heart and lungs aren't doing their job.
Exactly. You become the heart and lungs in those crucial moments.
Buying time until...
Until more help arrives, you got it.
And CPR, it's actually been around, it's gone through quite an evolution.
Oh, yeah. From, pioneering work back in the 1950s to those standardized guidelines we use today.
Always improving, always trying to increase those survival rates.
But speed, that's the key here.
Speed, why is it so crucial?
Think about it. Without defibrillation, brain death can start in under 10 minutes after the heart stops.
10 minutes, that's not much time.
It's a tiny window.
So CPR is all about buying those precious minutes.
Buying time by maintaining that circulation, keeping the ventilation going artificially.
And even though it might seem basic, done correctly, CPR can deliver up to a third of normal cardiac output.
Yeah, enough to keep those vital organs functioning.
Okay, let's say someone collapses right in front of you. How do you know CPR is needed?
Well, the big one is unconsciousness. No response.
You can't wake them up no matter what you try.
Then you check for breathing, check the pulse.
No pulse, no breathing.
That's when you got to jump into CPR immediately.
And something to keep in mind for the MCCQE, it's really important to remember when that person was last seen normal.
Or when you last felt a pulse.
Why is that detail so important?
It gives the medical professionals, the ones taking over, a clearer picture.
Like a puzzle piece.
Exactly. Adds to the overall story of what happened.
All right, you've assessed the situation. CPR is what are the steps?
Remember the 2015 AHA guidelines?
Those are key.
They focus on the CAB sequence. Chest compressions, airway, breathing.
Got it. That order matters, huh?
It's crucial for effectiveness. So for those chest compressions, you want to put your hands on the lower half of the sternum.
Okay, lower half of the sternum, then what?
Interlock your fingers, keep your arms straight, use your body weight to push down.
Push down how deep exactly?
At least 2 inches deep, but not deeper than that. Too much force can cause internal injuries.
Finding that balance.
Yep, a sweet spot.
So we've done our 30 compressions, then what?
It's time to open the airway. If there's no spinal injury suspected, you'll do a head tilt chin lift.
All right, head tilt chin lift then.
2 rescue breaths, each about a second long, just enough to see that chest rise.
And this whole cycle, 30 compressions, 2 breaths, just keeps going until help gets there or an AED is available.
Exactly, and minimizing interruptions, that's key.
So each pause, you're disrupting that blood flow.
That's right, it's about maintaining that continuous circulation.
Let's talk real-world scenarios for a second. As healthcare providers, what are some challenges we might face doing CPR, out in the field, not in a hospital?
Well, the ideal situation is having a barrier device, like a rescue mask, for protection.
Makes sense. Safety first.
But in a real emergency, that might not be available.
What happens then?
You have to think fast, weigh those risks and benefits.
Tough call.
Remember, compression-only CPR is acceptable for untrained bystanders, and sometimes it might be our only option, too, if we don't have a barrier device.
So it's all about adapting, doing what you can in the moment.
Absolutely. The main goal is to give that life-saving help, even if it's not the perfect scenario.
Now, what about if an AED arrives? What changes then?
So you'd attach the pads to their chest, following the instructions carefully. Then the AED analyzes their heart rhythm.
And based on that rhythm, it tells you if a shock is needed.
Right, and here's something they might ask on the MCCQE. Did you know there are actually different types of heart rhythms?
So it's using that rhythm information to decide if a shock will help.
Pretty sophisticated technology, right?
It is. So even with the AED, CPR is still part of the picture.
It all works together to give that person the best chance of survival. Even if the AED gives a shock, you need to go back to CPR right after.
Back to those compressions and breaths.
Yep, it's all connected.
So we've been talking adults so far, but what about when you come across younger patients, kids?
Yeah, pediatric CPR, that's a whole other ballgame.
It's got to be different, right? Working with those smaller bodies.
Oh, absolutely. Those tiny chests, you need to adjust your technique.
And you're right, the MCCQE, they'll definitely test you on this stuff.
For sure. So let's get into it. Pediatric CPR.
First things first, how do those compression decks change, between adults, children, and infants?
Good question. It all boils down to, well, you don't want to use too much force for those developing bones and organs.
Makes sense. Those little bodies are fragile.
So for infants under a year old, you'd use 2 fingers placed just below the nipple line
2 fingers.
and aim for a depth of about 1.5 inches. That's key.
Okay, 1.5 inches for infants, and for children, what's the target depth there?
For kids between 1 year and puberty, you'd use the heel of 1 or 2 hands, depending on their size.
So similar to adults in that way.
You'd position it on the lower half of the sternum, just like we talked about before, but the depth is closer to 2 inches.
2 inches for children, got it.
Look, again, it's all about adjusting for their smaller frames.
Okay, so technique-wise, it's pretty similar, just smaller movements.
Right, the principles are the same, just scaled down.
Now let's shift gears a bit. Let's say we're talking CPR in a hospital setting.
Oh yeah, totally different environment.
More resources, a whole team around you. How does that change things?
Well, for one, you have access to more advanced equipment, like a bag valve mask, the BVM.
The BVM brings back memories from my rotations.
It takes practice, that's for sure.
Getting that seal right, it's a skill.
But it's super important for delivering those breaths during in-hospital CPR.
And speaking of breaths, the compression-to-breath ratio, does that change too when you've got multiple rescuers?
Absolutely. It's not always that 30.2 we discussed earlier.
So with one person on compressions and another on the BVM, what's the new ratio?
It becomes 15 compressions to 2 breaths, a bit faster paced.
And if the patient's intubated, what then?
In that case, compressions can be continuous, with someone else delivering breaths through the BVM.
Continuous compressions, wow. So it's really all about coordinating with the team.
Exactly, ensuring both circulation and oxygenation are happening consistently.
It's like a well-oiled machine, everyone playing their part.
That's the ideal scenario, working together seamlessly.
Let's talk about the big picture now. The outcomes for someone who goes through cardiac arrest.
Yeah, what are the chances of survival?
What does Stat Pearl say about the prognosis?
Well, this is where things get a bit serious, unfortunately. The survival rate for out-of-hospital cardiac arrest, it's still pretty low.
Really? How low are we talking?
We're looking at only 10.6% overall survival to hospital discharge.
That's a sobering statistic.
And of those, only 8.3% have good neurological function.
So even if they survive, there can be lasting effects.
That's right. It's a reminder of how critical those first few minutes are.
But like you said before, early recognition and high-quality CPR can make a difference.
Those are the factors that can really improve outcomes.
But even when done perfectly, CPR can have complications, right?
Yeah, you're applying force to the chest, so rib fractures, those are pretty common.
And those can't be easy to recover from, especially for someone already in a fragile state.
Exactly. And in some cases, those rib fractures can even lead to a collapsed lung, what we call a pneumothorax.
So another layer of complexity to consider
And then there's also the risk of hypoxic brain injury.
because of the lack of oxygen during the arrest.
It's a multifaceted situation, trying to save a life, but also being aware of those potential complications.
A lot of responsibility on our shoulders as future physicians.
Exactly. It takes skill, knowledge, careful judgment, which is what the MCCQE is all about, assessing those abilities.
You've given us a lot to think about, really painted a complete picture of CPR.
From the steps to those real-world considerations.
But let's move beyond just the physical aspects of CPR now. You mentioned ethical considerations earlier.
Right, the tough calls we might face out there in the field.
Especially when it comes to CPR. Those decisions can be really difficult.
It's where things get complex, thinking about things like limited resources, tough environments, or even the patient's own wishes about resuscitation.
That brings up DNR's do not resuscitate orders.
Oh, yeah, DNRs, those can be really challenging, ethically speaking.
Even though it's about respecting a patient's autonomy, it's still a heavy decision.
It's not just about a piece of paper, it's about real-life situations.
Especially in those chaotic out-of-hospital settings, you have to be prepared for anything.
Imagine having to talk to family members who might not agree with the DNR. Those conversations can be incredibly tough.
Emotionally charged, for sure.
And as future physicians, we need to be equipped to navigate those situations while still providing the best care possible.
It's not just about knowing the steps, it's about understanding the whole context, the weight of those decisions.
Exactly, and those are the kind of scenarios the MCCQE might throw at you.
Not just to test your knowledge, but to see how you think critically under pressure.
You got it. It's about making those tough judgments in difficult situations.
You've given us a lot to ponder. Really brought those real-world challenges to light.
Well, that's what we're here for, to help you prepare for anything.
Before we get too far ahead, let's wrap up our CPR deep dive for today. Okay, so big picture, we've covered a ton today.
Yeah, from the basics of CPR, the steps, to, thinking about pediatric CPR and even those ethical dilemmas we might face out there as doctors.
And it's clear that CPR, this is a fundamental skill, right?
Absolutely. Bread and butter for any healthcare professional.
And the MCCQE, they're definitely going to test you on this.
Oh, yeah, you'll see it pop up.
But remember, this deep dive, it's just the beginning, right?
Exactly. It's a starting point. We always encourage folks, go get that certified CPR training.
Get those hands-on skills.
Yeah, nothing beats real-life practice.
It gives you that confidence to, act fast when it matters.
So as we wrap things up, we wanted to leave you with something to think about.
Okay, I like that.
How do you think all this amazing technology out there, how might it change CPR, in the future?
That's a good question. What's next for CPR?
Could we see AI-powered CPR devices?
Imagine that.
Or maybe some totally new ways to deliver oxygen, keep that circulation going, something beyond what we can do manually.
Wow, that's fascinating to think about.
It really is. The future of medicine is always changing.
And as doctors, we need to be ready for that, ready to learn, to adapt.
Absolutely. Staying curious, keeping up with those advancements, it's all part of the journey.
You've given us so much to think about today.
Well, that's what we're here for. Happy to share what we know.
And to everyone out there studying for the MCCQE, keep pushing, keep learning.
Yeah, you got this.
We're rooting for you.
Okay, folks, that's it for our deep dive on CPR today. Hope you found it helpful.
And a huge thank you to you for walking us through all this, breaking it down.
It was my pleasure. Always love talking about this stuff.
And to all you future doctors out there, keep diving deep into the world of medicine. It's an incredible journey.
Couldn't agree more.
We'll see you next time.
Take care, everyone.